Hi, everyone, and welcome to this session. The TechNet Network is super happy to host this session on the SAGE update on immunization meeting. Um, this session is recorded, and we have interpretation into Spanish and French. If you want to listen to this session in French or Spanish, please check the globe at the bottom of your Zoom window. There's an interpretation icon. Click on it and select the language you want to listen to this presentation. Apart from that, as I said, the session is recorded. Louise, we're going to send the recording later. Is it planned?
Yes.
Yes. So we're sending the recording by email later on after this session. I'm giving the floor to Mario to start this session. Thank you very much, and I hope you enjoy it.
Thank you, Joaquin, and it's a pleasure to be here. Hi, everybody. So this is our GNN webinar, and it's going to be a SAGE Digest. As you may know, you should know the strategic advisory group of experts from WHO met last week, and I had the opportunity to attend the meeting, and I can tell you that it was a really uh, a very good meeting with a lot of discussion, and of course, a lot of things that I know you as NITAGs are going to be very interested in. Uh, I think that we all NITAGs should be at least aware of what SAGE is recommending, and I think this is a great opportunity because we not only have the chance to know what's going to be recommended, but also the discussion behind that recommendation, which I think it's very important for us. So I'm very happy that we have the privilege to hear firsthand what Sage discussed last week, and I'm gonna leave you with Hannah, who's gonna start telling us what happened in the meeting. Just about housekeeping, the questions you can do it through the chat, or you can wait at the end if you want to ask any questions, and you can raise your hand. We'll give you opportunity at the end of the meeting, but anytime you can send the question to the chat. So I think we can start.
And we hand over to Joachim for the first slides.
Yeah. So hello, everybody. My name is Joachim Hombach. I'm the Secretary of SAGE, and I have pleasure to start this webinar together with Hannah Neuneck, who is the chair of SAGE, and will provide with an overview on the outcomes, and then we'll have later 3 specific sessions on the so-called big catch-up on polio and on Mpox by colleagues. Let me just say, I mean, first of all, it's really a pleasure to be on this call. I hope that some of you, or even many of you, have been able to attend and to link into the SAGE meeting that we had last week. You see here the agenda. We actually had relatively few agenda items for policy recommendation. They're linked here with the asterisks. So polio, hepatitis E, and Mpox. But we had a number of other sessions that were equally important and to some extent developed the case for future policy recommendations. So when we look at the agenda, we had actually 4 themes. We had a moment of celebration around the 50th anniversary of EPI. We had, as we regretfully have since many years, we have a lot of discussion on outbreak response and policies and strategies around outbreak response. And this relates here, obviously, to Mpox, to polio, to hepatitis E. And we had not on the agenda also discussions in relation to yellow fever, cholera, and measles, of course. We had a deep dive into programmatic issues that relate to the so-called big catch-up. So the catch-up on the slippage of immunization following the COVID pandemic. And this is being discussed in the Immunization Agenda 2030. And again, we'll have a specific presentation. And then we had a couple of items which are here grouped under the immune correlates. and respiratory syncytial virus, RSV, in relation to recently licensed vaccine or future vaccines that will come to SAGE in the near to medium term for policy recommendations. And these were discussions to prepare the ground. So let's go to the next slide. I'll just say a few words on the global and regional reports, and then I actually hand over to the chair of SAGE. So let's go to the next slide, which is essentially around the 50-year celebration of EPI, which started in 1974 with 7 antigens and with a DTP3 coverage of around 5%. Today we have 13 globally recommended vaccines, many then contextual vaccines in addition, and we are on average at around 85% coverage for DTP3, but we want to get better. And what you see here on the right-hand side is an estimation of the cumulative effect of vaccination on survival. And you see it here by age, and you see this very massive impact immunization had on child survival, and then down from there also to adult survival, which is really absolutely spectacular. And immunization is and has been and will be driving really the child survival agenda, and has developed really into the foundation of primary health. Next slide gives you just a couple of elements in terms of innovation that have been really facilitating and helping this incredible success. And here you see the listing of innovations in relation to vaccine development, vaccine technologies, manufacturing, but also in relation to storage and handling, as you see down here. So I think this has been really an incredible journey, and many other innovations also in the space of programs and management and data clearly have made this possible. So let's move on to the regional reports very quickly. We heard, as we always do at SAGE, which is very important for us, feedback from the 6 WHO regions in terms of their work over the past 6 months and their particular issues and challenges, and they're extremely important for us. I can't go here through the details. You have obviously also the link to the SAGE highlights. The link was actually on the first slide. I forgot to mention this. What you see as a couple of common themes is obviously that all regions had these major setbacks in vaccination, but there is recovery. The recovery is somewhat uneven and regretfully not progressing very well in the African region. But we see overall progress, but we still have major lapses, and in particular also in relation to measles, vaccines and vaccination. And as you know, we have a lot of outbreaks across the world. There was again, and this is important for NITAGs in particular, the note that really all countries should have established and kind of regular catch-up vaccination schedules that are just, as it's written here, kind of firmly embedded into immunization programs. And many countries have acted upon this and have done this and have also removed unnecessary barriers to immunization, but there's still work to be done. We heard about great progresses in certain countries. In particular, India was mentioned that had really found an approach in a targeted manner with also accountability across all levels to promote vaccination and to recoup for the losses that occurred during the COVID pandemic. Another thing which is important is the issue of the ability to monitor, and we'll hear more about this by Carolina, which is really a really important thing. to have monitoring, to have surveillance in place. Otherwise, we are blind to what we are actually doing and have difficulties to course correct. And then another point which SAGE actually had made several times, we have obviously and regretfully more and more fragile and conflict-affected areas where we need program flexibility in order to deliver the most important life-saving vaccines. And program flexibility means also flexibility around schedules. And so this is also something if NITAGs may want to look into their guidance in countries in terms of providing this flexibility as needed for these specific circumstances. I think this is all what I wanted to say in terms of the general introduction, and I'm handing over to Hannah Neuneck, who will walk us through some of the specific recommendations.
Thank you very much, Joachim, and a very good morning, good day, good afternoon, good evening to every one of you. And I hope that you were able to follow our meeting online last week. And this is to summarize where we landed on after reviewing the evidence and discussing with the working groups and with the SAGE members on the recommendations. So hepatitis E is the first one. As you know, there is a current WHO policy. Let's have a look into the burden of the disease and severity, and also what the Global Advisory Committee on Vaccine Safety said in its review on the hepatitis E vaccine safety. And then we'll look into the reduced dose schedules and the final recommendations. So this is what I'll be reviewing with you just now. Next slide, please. So hepatitis E is an endemic and epidemic disease, mostly in low-resource areas where large outbreaks occur, especially in Asia and Africa. But I have to say that we are presently having an outbreak here in Finland as well. So it is nobody's kind of free from it if there is bad luck. The morbidity is high, and mortality is as high as 25% in those pregnant in the outbreak. And currently, there's only one product available, Hecoline, it's called, and it has got a license in several countries, but it doesn't have the WHO pre-qualification. It's for the label, it's meant to be used in individuals 16 years and above, and the schedule is 3 dose, 0, 1, and 6 months, as usually hepatitis vaccines are, hepatitis B, for example. The pre-filled syringe with an approved shelf life has at least 36 months, and it can go up to 45 months under appropriate storage conditions. And in studies, it's been proven with very high vaccine efficacy with 3 doses, 100% with the narrow confidence intervals, and even with 2 doses, 100% with the wider confidence interval and maybe shorter duration of protection. The WHO issued a vaccine position paper in 2015, but it's not routinely recommended in anywhere. Its use is for to vaccinate, to mitigate or prevent the outbreaks of hepatitis E. It's registered in China and several other countries, but as said, there is no WHO pre-qualification yet. And what we've observed that it is underused, especially in the fragile, conflict-affected and vulnerable settings, with the timely access being one important barrier. Once the epidemic is over, if the vaccine hasn't arrived, then there isn't much indication to use it further. The hepatitis E vaccine stockpile has been approved under the International Coordination Group on vaccine provision in October 2023. And next slide, please. The safety of the hepatitis E vaccine during pregnancy is known to a certain extent. There is limited data on the use of hepatitis E vaccine in pregnant women in China and South Sudan, and those have not identified any serious safety signal to date. There were no safety concerns observed in other protein-based vaccines during pregnancy, so one would expect this to be safe. But then, however, there was a cluster randomized trial in Bangladesh that had an elevated risk of spontaneous abortion, which needs to be investigated further. The paper is not out yet, but we hope that it will be available, hopefully fairly soon. Then judging based on that safety signal of what is known from other studies, the risk benefit in fragile and conflict affected and vulnerable settings favors vaccination, given the high hepatitis E related morbidity and mortality in pregnant women. And it's important to generate much needed evidence on the use of this vaccine during pregnancy, given the substantial burden of hepatitis E in pregnant women and the high risk of infection and subsequent complications. So that was what the Global Advisory Committee Vaccine Safety concluded, and it was agreed upon by the SAGE as well. Next slide, please. So the SAGE recommendations, to summarize, is that in fragile, conflict-affected and vulnerable settings with documented hepatitis E virus circulation, where the risk of severe disease during pregnancy is high, the benefits of vaccinating women with childbearing age, meaning from 16 and above, outweigh potential harms. And when implementing vaccination campaigns, SAGE stressed the importance of accompanying hepatitis E vaccine use with learning agenda whenever possible, so that data is being collected and analyzed so that we can understand more both the impact on the effectiveness and the safety. SAGE approved the use of a 2-dose schedule, meaning 0 and 1 month, instead of the 3-dose schedule during campaigns in these kind of fragile, conflict-affected, vulnerable settings. And SAGE encouraged additional research on hepatitis E vaccination during pregnancy in people living with HIV and in individuals under 16 years of age. In addition, SAGE asked to be informed on the outcome of further analysis of the Bangladeshi trial. Next slide, please. Then we move on to immune correlates. As we know, there are several vaccines and diseases where the immune correlates of protection are very well known. And for some vaccine, we know that the phase 3 trials with clinical outcomes are challenging, either because they require very large sample sizes or because of the unpredictability of these outbreaks, and then the regulatory approval may be issued based on immunological correlates of protection. SAGE was briefed on the proposed regulatory pathways using this approach for chikungunya and group B streptococcus vaccines, and the evidence in support of the proposed immunological correlates of protection. A chikungunya vaccine, which is a live attenuated vaccine, has been licensed by the US FDA based on immune correlates, and the GBS vaccines, which is a protein-based and hexavalent glucoconjugate vaccine, is likely to use a similar pathway. Next slide, please. So SAGE discussed the matter. There's a whole lot of issues of principle, but we arrived to the conclusion that since a chikungunya vaccine had received regulatory approval and there was interest in introducing this vaccine in several countries, SAGE advised WHO to initiate a process to conduct a detailed review of the evidence and assess use case scenarios for the optimal use of this vaccine. And SAGE also noted that requiring evidence of clinical efficacy of Group B strep vaccines before issuing recommendations could delay registration and ultimately the use of the vaccine in low and middle income countries. Therefore, SAGE advised WHO to develop guidance on evidence needed for policy for vaccines where market authorization is provided in absence of regulatory authorization. Next slide, please. Then SAGE did have a look into COVID, and this was not for any recommendation, it was more for information. SAGE took note that COVID continues to circulate widely across the globe, and there are regional variations worth noting. And the wastewater trends suggest increased activity in some Southeast Asian and Western Pacific countries subnationally, while trends of reported cases have stayed stable. And there is an impact of reduced testing in this. The weekly numbers of reported deaths are now consistently below 4,000 since mid-May 2023, and they have been reported from an average 50 countries. And the number of countries sharing death data remains very low. As such, the actual numbers of death is presently unknown. There is limited reporting on hospitalization data, and reporting delays make it very difficult to draw strong conclusions from trends in hospitalizations. And COVID-19 isn't the only pathogen circulating stressing healthcare systems. The JN1 is the most prevalent variant right now. It's currently evaluated to pose low public health risk. However, the virus continues to evolve, and we do not yet have seasonality or predictable temporal patterns. The seroprevalence against SARS-CoV-2 is high, with some heterogeneity by age, and the declining and unrepresentative surveillance and sequencing is making it more difficult to rapidly assess known variants and detect new ones or recombinations. Next slide, please. So if you look into the vaccine uptake, it has declined substantially since its peak in late 2021. 120 million doses were administered during the July to December last year period. And there are differences if you look into the geographic areas. Next slide, please. So the SAGE observation on COVID-19 was that the number of cases, hospitalizations, and deaths from COVID-19 continue to show a declining trend. We know that there is inequity in access to COVID vaccines, and they persist, while the demand has declined, especially in low and middle-income countries. Revaccination with Omicron-adapted bivalent vaccines continue to protect against symptomatic and severe disease during the XBB dominant period. There is a moderate benefit of the monovalent XBB vaccines over the bivalent or index virus vaccines. And so SAGE reiterated its recommendation that the monovalent XBB vaccine should be used when available. However, SAGE recognized that countries should not delay administration of ancestor or bivalent vaccines to high priority use groups if monovalent XBB vaccines are not available. And SAGE reaffirmed the priority use groups and frequency of the revaccinations as outlined in the WHO SAGE roadmap for prioritization the use of the COVID vaccines. SAGE will be revisiting the roadmap and the epidemiology and vaccination situation in its next meeting in September this year. Next slide, please. Then finally, SAGE had a look into the RSV vaccine and monoclonal antibody situation. In infants, it's been consistently been observed across country income categories that the RSV vaccine effectiveness is good, as shown in this table of the systematic reviews. Next slide, please. So RSV was provided, SAGE was provided with the RSV data on products that recently received regulatory approval for prevention of RSV disease in infants and adults. And these included the RSV pre-F protein vaccines for use in pregnant women to provide protection to young infants and to protect older adults, and long-acting monoclonal antibodies to protect young infants. All products have demonstrated high efficacy in protecting the target groups against medically attended and severe RSV lower respiratory tract illness. However, a numerical imbalance in preterm births was noted in pregnant women of the vaccine group in middle-income countries. The products have been rolled out in a few countries, as you can see here. Next slide, please. So the observations that SAGE had on RSV was that we will be waiting for the deliberations and suggestions for recommendations by the working group that is reviewing the evidence on the use of these products, and the findings of their review will be presented in the September SAGE meeting. SAGE recommended that products for the prevention of RSV disease in infants be prioritized for presentation in September because we are very well aware of the global burden of RSV in infants. However, the burden on the elderly is not that well known in many high-income countries, let alone the low-middle-income countries. So that then will be followed by the vaccines for protection of older adults, and articulated several issues that should be considered by the working group in their review of evidences. And SAGE highlighted the need for collecting adequate data on safety of the vaccines during pregnancy in low middle-income countries where the safety signal has been seen. Next slide, please. With that, I give it over to the next speaker on the IA 2030 deep dive.
Anna, before we move on, we'll just take questions and answers before we move on to Carolina.
Gladly.
Are there any questions?
There's a question in the Q&A box.
How accessible are Omicron-based SARS-CoV-2 vaccines? They are not available yet in South Africa.
Maybe Joachim has got the best understanding of the present situation. The access is limited, but how many countries of the member states do not have the access to XBB vaccines right now? Joachim, do you have the figure?
Yeah, I don't have the precise figure. It was actually also briefly discussed at the SAGE. There is, on balance, no shortage of XBB vaccine, and there is a UNICEF tender. But we know that manufacturers are not licensing the new vaccines, the updated vaccines, widely. So, and I know, for instance, that's the case in South Africa. So I think this is indeed an issue. I'm just looking up. So in terms of WHO pre-qualification or emergency use listing, we have Pfizer XBB vaccine, which is emergency use listed for WHO. We have also Novavax, and then there is others like Moderna and Covovax, which is, so to say, the Novavax biosimilar, and also Hipra, which is a protein subunit vaccines, which are, so to say, in the making. So we have a bit of an issue of demand and supply. There is little demand, potentially also little perceived demand, which then also makes it less attractive for manufacturers to license. And but maybe also there is little demand because there is not so much vaccine, license. So it's very difficult to disentangle. But we are aware that it's not always straightforward. Having said this, the ancestor vaccines still have utility, but I totally understand the drive and the desire to have access to the updated vaccines.
And then there is another question. There are cases of measles and pertussis happening in children less than the age for the first dose. Has there been any discussion on that, especially decreasing the age for the first dose of measles?
Thanks for that question, and that actually was discussed in the closed session on lowering the age of measles, and the work is ongoing to looking into on what we know of the immunogenicity, duration of protection, and then rescheduling the program from there on. So we are working on that in WHO and SAGE, and Joachim knows better on when actually would be the time point to share this information with the regions.
The only thing I can say that in relation to measles, if I may add, in our current policy, which is, I don't know, from 2017-18, we refer to early in life, so below 9 months vaccination down to 6 months of age in specific circumstances. So if there's really a specific circumstances of risk, there's some countries, again, South Africa, that have moved to routine early schedule. We are currently in the process of evidence reviews in relation to the early in life measles vaccination. The vast majority of measles cases, however, is in older age groups. But having said this, there's nevertheless indeed a concern that, in particularly with maternally transmitted antibodies that are not stemming from infection, but from immunization, these antibody titers are lower. And hence the waning of maternal immunity in infants may be occurring somewhat earlier than it used to when mothers had antibodies due to infection.
Thank you. Seeing no other questions, feel free to add to the Q&A, but we'll move on to the next presentation on AI 2030 and the big catch-up with Carolina. Over to you, Carolina.
Thank you. Will you pass the slides or should I share my screen?
I'll pass the slides.
Okay, thank you. So hi, everyone. I'm Dr. Carolina Danovaro. I'm a medical epidemiologist with the Immunization Analysis and Insights team in WHO Geneva. So we had a deep dive for the Immunization Agenda 2030 in the topic of Big Catch-up. So the Big Catch-up, it's an initiative that was launched last year that has 3 pillars. The pillar of closing immunity gaps through catch-up. Second pillar of restoring coverage levels to the levels seen before the pandemic. And thirdly, to strengthen routine immunization systems so that they also include catch-up as a routine and regular activity of leaving no one behind. So as part of that, some countries are now receiving some funding to do more activities related to bringing up to speed children who were missed in the last few years, so mostly up to 5 years. And SAGE was presented with the initiative. And really, for the initiative to work, SAGE underscored the importance of the political will, engaging communities, because in many countries, vaccinating older children is not really a routine thing, and tooling the health workers so that they are aware of how to ascertain the eligibility for the different vaccines for older kids, and then record and actually vaccinate kids and record the doses properly. And also SAGE encouraged that the National Immunization Technical Advisory Groups, are engaged in guiding these efforts to catch up older cohorts. So the monitoring of the big catch-up, it's really important to understand how the activity has worked. If we have caught up children that were missed previously, and also to understand any impact of that in the routine immunization program. So to that end, the Immunization Agenda 2030 Data Strengthening and Use Working Groups, one of these many working groups that support the implementation of the data-driven Immunization Agenda 2030, developed a guidance document. There will be a link in a different slide, and with indicators and how countries can go about monitoring catch-up. And then SAGE acknowledged really that in many settings, because of the limitations of the data systems, we will not have necessarily granular data to fully monitor the impact of the catch-up efforts. So also that we will have to deal with pulling the pieces together and doing triangulated analysis. The next slide. So as I said, to launch this big catch-up initiative, the priorities for this year are each country is doing according to its needs. So it's tailored. There is resource mobilization ongoing. There are policies and practices that need to change. For example, in many countries, there were no catch-up schedules, and really things have to start from changing the policies to changing the practices, the standard operating procedures, and then the tools to do this. And then also one priority is to engage with different programs, for example, with the polio program. Next slide. So this is the guidance I was telling you that is out now in 4 languages. Today we put out the Arabic version, so it's already in 3 languages in the TechNet page, and the Portuguese is forthcoming, and includes guidance on how to do readiness to see if you're ready to do more intensified catch-up activities. A whole chapter on the health information systems for setting up how they are going to collect and aggregate and look at the data. And then for in-process guidance on doing real-time monitoring and targeted assessments. And finally, this idea that because we will not be able to get granular data, we'll have to rely on some case studies with mixed methods and surveys. Next slide. For readiness monitoring for countries that are a priority for the big catch-up, the regional working groups and the regional entities are coordinating the monitoring of how ready the countries are. And of note, Gavi, for the countries that they are supporting, they will be collecting, requesting updates on data. So they would be requesting a big catch-up monitoring form, but it's aligned with the guidance developed by this multi-agency data strengthening and use working group. Next slide. So the kinds of things that are included in the guidance, and one of the most important, even though it seems simple, is to ascertain whether the child in front of you as a health worker, it's eligible and for which vaccine. And that really relies on having a card, but in many instances, cards, particularly in older children, are not available. So how to go about that with some questions. Next slide. As I said, the health information systems are really crucial. So they need to be adapted to allow for the disaggregation of different age groups. And the cards need to really be adapted and available to be given, for example, to older kids. And once you have the basics of the paper-based recording systems, to also adapt your aggregated data management information systems, and also not only having the tools adapted, but really the health workers need to understand how to fill the forms, how to aggregate, and then all the way up to how to interpret the data that now will be more disaggregated. Over. Next one. For the in-process monitoring, for countries particularly where vaccination of older children is new, we recommend in this guidance to do rapid convenience monitoring or similar assessments like LQAS to detect problems immediately and include the behavioral and social drivers of vaccinations to understand any barriers to vaccinating older children. And then from the provider side of things is to adapt tools like exist on readiness of the immunization system, including adapting tools like the mini-PI or the missed opportunity methodology to really see where we are missing kids who would be eligible for catch-up. Next slide. This is just summarizing the indicators for number of children vaccinated and how that will be also reflected in the Gavi form for Gavi-supported countries. Next slide. And then finally, the suggestion of really doing deep dives and case studies in some countries where we want to learn more, and surveys with the caveat that surveys will rely on cards, and cards are not always there, but with surveys you will be able to see the age at vaccination. Next slide, and I think it's the last one. Second to last, I think in summary, there are many challenges and we are trying to propose ways of mitigating the problems. At country levels, as I said, determining the eligibility is an issue in many cases. The data tools and systems that need to be adapted. home-based records, not only they have to exist, but they have to be filled in properly and kept. And then we will have some mix of data where probably children who are more than 12 months have been recorded as being less than 12 months, so that can artificially inflate coverage. And then, of course, there are concerns about the funding and time. The graphs on the right are just to illustrate that 60% globally of countries said that they do have a system to allow for this, some age disaggregation. But when the bottom graph, it just illustrates that the data coming to HQ, it's very incomplete, but also it's not in the slide. Also, sometimes the proportion of, for example, measles-containing vaccine in countries that are recommended at 9 months, that is recorded as reported as given to a child over 12 months, let's say it's less than 1%, and then you go to a survey, and among those, at least those with cards, is like 10%. So there are big mismatches of data, and that will be difficult to really disentangle the different age groups, and also disentangle children who were really actually not vaccinated for that dose. At the global level, the challenge is that it's an heterogeneous initiative, and that we have limited data collection around this. And then WINIC, the WHO UNICEF estimates, are really looking at one cohort. So they don't really, it's not set up to capture how that cohort of children got caught up later. And the last slide, I think that's the last slide. Yeah, thank you so much. Any questions? I'm here.
I don't see any questions yet for Carolina. Thanks, Carolina, for the presentation. We do have a question from the previous presentation. I think maybe Joaquin can answer it really quick. And this is, do we have information on efficacy of chikungunya vaccine, the chikungunya vaccine that has been already approved by FDA?
Yeah, I can say a few words. So the FDA has licensed the vaccine on the basis of an immunological correlate, as it was explained by Hannah Neuinek, which was based on essentially non-human primate challenge studies that were passively transferred with human serum. So there is some indirectness. The indirectness, I mean, it's suggestive that the vaccine will be highly effective given the immunogenicity of the vaccine in humans. It's a live attenuated vaccine, but we do not have a specific efficacy measure at that point in time.
Thanks, Joaquin. And we have a question for Carolina. Is GIW being utilized for the big catch-up?
If GIW means Global Immunization Week, partially yes. World Immunization Week, so I'm not sure if the same thing, but if it is that, yes. But in some cases, for some of the Gavi supported countries, the timing is not going to coincide. It's going to be later because they are now requesting the extra doses. Thanks.
And seeing no other questions, Mario, I think we can move on to polio.
Sorry, there is another question of whether the big catch-up addresses policies for adult vaccination platforms.
Oh, sorry. Thanks, Anna.
No, the main focus is still catching up children. So it's not necessarily part of the initiative, even though that would be useful in many settings. Over.
Thanks.
Thanks. So moving on to polio, Andres, will you be sharing your slides or do you want me to?
Good afternoon, good morning. I'll share my slides if that's all right with you. Can you see my slides, please?
We can.
All right. So I'm Andre Mach. I work in the polio department and WHO headquarters, and I am a focal point on the SAGE for polio. So before I go into what we discussed at the SAGE session, I just want to show you where we are with polio eradication in general in terms of epidemiology. This map shows paralytic cases caused by polioviruses in 2023, and the red dots that are in Afghanistan and Pakistan are paralytic cases caused by wild poliovirus serotype 1, and they were only 12, 6 in Pakistan and 6 in Afghanistan. So 2023 has been a very successful year for polio in terms of wild poliovirus 1 eradication and achieving finally the last goal post of eradication of the wild virus. On the other hand, you can see a lot of green dots throughout Africa and orange dots as well, which are circulating vaccine-derived poliovirus cases caused by CVDPV serotype 1 or serotype 2, the green dots, and serotype 1, the orange dots, and there are several hundred of those. So you can see that we are still battling outbreaks of vaccine-derived polioviruses caused by mutated virus from the OPV, from the oral poliovirus vaccine, throughout Africa and in some Asian countries as well, such as Yemen or Egypt. So now I'll go to the SAGE meeting and what we discussed. There were 2 items for discussion and recommendation for this meeting. One was to discuss the policy framework and triggers for bivalent oral poliovirus vaccine, the bOPV cessation planning. And what I showed you on the previous map clearly shows the need to withdraw the use of oral poliovirus vaccine, the live vaccine that in rare circumstances can start circulating and causes outbreaks. The second item that was discussed was the recommendation on use of fractional dose IPV or FIPV administered intramuscularly. And I'll discuss both of these items in a little more detail in the next few slides. So what is the bOPV cessation? Just as a background, clearly it's a global withdrawal of bivalent OPV from routine immunization, which follows certification of eradication of wild poliovirus. So in essence, all countries at that moment will become IPV-only using countries. And there is consensus that use of live poliovirus vaccines, such as OPV, is incompatible with poliovirus eradication. And you may remember that this first step in this process in the OPV cessation was the global switch from trivalent to bivalent OPV, which happened in 2016. So one of the items that was discussed at the SAGE were lessons learned from that switch in 2016. And when SAGE reviewed the key findings from the independent evaluation of the switch, they agreed that the switch was an unmitigated failure, unfortunately. And you can see why, because the overriding cause of the cessation of type 2 of that switch was the inability of the program to close out outbreaks with timely manner. And you can see that in 6 years prior to the withdrawal of OPV type 2 between 2010 and 2016, there were about 300 cases of paralysis caused by CVDPV2 cases. And the objective of the switch was to avoid these cases, but just the opposite happened. The 6 years after the switch, instead of 300 cases that we saw before the switch, we saw more than 3,000 cases. So one of the lessons was that the switch was an unmitigated failure and that we have to be extremely careful going into the cessation of OPV not to repeat this type of a failure. So SAGE deliberated and concurred that the current timeline for the cessation in 2027 will not materialize. This was the original timeline that the program planned for. And this is given the uncertainty of our ability to stop WPV1 and CVDPV outbreaks. The SAGE members strongly supported that the bOPV cessation should only be done after all CVDPV2 outbreaks are stopped. And this is to prove that it's actually possible that we are able to do that. There would be little logic in trying another cessation of OPV when we haven't succeeded with the original one in 2016. SAGE also recommended that low polio risk countries, and this is an important recommendation for the program, with at least 2 IPV doses in their routine immunization should consider transitioning into IPV-only schedules ahead of planned synchronized bOPV cessation. So this is a signal to regions such as maybe Wipro, Euro, or PAHO to start thinking about removing OPV from their schedules ahead of the synchronized bOPV cessation. So I'll go now to the second item, and that was the fractional IPV and the current options for intradermal administration. You may recall that an off-label fractional IPV, which is 1/5 of a dose of normal IPV, in other words, 0.1 milliliters of IPV, administered intradermally, is used successfully with needle and syringe in some countries in their routine immunization schedule. These countries are Sri Lanka, India, Bangladesh, Nepal, Cuba, and Ecuador. And we have assessed these programs in these 6 countries, and they function very well. Apart from that, intradermal fractional IPV campaigns have been used in several countries as a response to polio outbreaks, either for wild or CVD-PVs. But these countries that don't use it in routine immunization face problems with needle and syringe injection, or with the injection with what is pictured here on the right with the Pharmajet Tropis needle-free device, which is a pre-qualified WHO needle-free device. However, it has its problems, the cost is high, and the logistics are difficult to maintain with this device. So WHO was looking for other ways of administering fractional IPV. We have done 2 studies looking at inferiority or non-inferiority of fractional IPV administered intramuscularly compared to intradermally. One was in Cuba in slightly older children, in children 4 months and 8 months old, and the other one in Mozambique in children of 2 months and 4 months old. Both of these studies demonstrated non-inferiority between intramuscular and intradermal administration of fractional IPV. Based on these study results, SAGE concluded that it is possible for countries responding to persistent poliovirus circulation to choose the mode of administration of fractional IPV, either intradermal or intramuscular, for outbreak response campaigns. So this recommendation does not apply to countries that use fractional IPV in their routine immunization, but expands the option for using fractional IPV for outbreak response to do it intramuscular, which makes it easier in terms of training of the vaccination teams to do a good campaign. So just as a summary, SAGE was pleased to note that wild poliovirus circulation is confined to a small geographic area. However, SAGE was concerned about the continued circulation of vaccine-derived polioviruses in Africa. SAGE was very focused on stressing the need to increase efforts to improve routine immunization coverage, especially with the first dose of IPV1, and also to accelerate introduction of the second IPV dose in all countries. SAGE extended its support to the bOPV cessation team in planning for the eventual cessation, and will review the triggers and prerequisites developed by the team to ensure a successful cessation. So again, SAGE tries to make sure that we do not repeat the mistakes from 2016. The important programmatic recommendation is that SAGE reiterated that only low polio risk countries with high coverage with at least 2 IPV doses may consider transitioning to IPV-only vaccination schedules. And the RAS recommendation I mentioned already about the option to use fractional IPV for outbreak response intramuscular. So that's all I have. Thank you so much.
Thank you, Andres. And we do have a question for you. Does WHO designate individual countries as low, medium, or high risk polio countries, or only WHO regions?
Yeah, yes.
And further to that, I'm sorry, is South Africa considered a low polio risk country?
So every year, every WHO region designates the individual countries to low, medium, and high polio risk. I don't have that table with me right now, so I cannot answer whether South Africa is considered a low polio risk country, but we can have a look at the latest AFRO designation of countries and come back to you. And I know South Africa is one of the countries considering to transition to IPV-only schedules. And this was discussed in particular during the working group SAGE meeting as well. Thank you.
Okay, and they're asking also where do they find this table? And another question is, as the initial plan was interrupted, WPV and bDPV still 2023. I have access after that. And we were at a welfare virus case in Pakistan. How does this affect the PI agenda to timeline?
So obviously the timeline is revised all the time. You may recall that the first target for certification was year 2000. So we are 24 years late, just to say. Right now, we are hoping for certification in 2026, in the end of 2026, because we do have positive signals from Pakistan and Afghanistan. I'm talking about certification of wild poliovirus, because there needs to be 3 years of no circulation between the certification is possible. So we are looking at end 2026 or 2027. We also plan for CVDPV2 certification in 2028. So right now, the bOPV cessation is probably realistic in 2029. But again, you know, these timelines have been changed so many times that it's difficult to, you know, have certainty in this. Thank you.
Thanks. And we have a question from Yvette. Can you open your microphone and ask the question?
Yvette, can you unmute yourself?
I don't think it's possible. Have you? Have you given it? Okay, you have given the possibility to unmute yourself. Yvette, you can unmute yourself. We can unmute. We can unmute it for you if you want. Okay, now she can. Okay, Yvette.
Maybe Yvette is gone.
She's still here. I see the microphone is unmuted, but we can't hear her.
Okay, so then let's take Yvette. If you're hearing us, then please put your questions in the chat. And I think we will move on if there is no other questions.
There are 2 questions in the Q&A box.
Yeah, Andrej, you refer to the table. Where can they find the table?
Yeah, I can try to you know, contact the regions. This is an annual exercise as far as I know, and I'm not sure that it's published publicly somewhere, so I'll try to find it.
And then I don't know how comfortable you are, but there is a comment about being convinced to transition or not.
I think Shabir Mahdi, as you know, is the chair of the polio working group of SAGE. And I think he believes that South Africa is ready for transitioning. I think it's a discussion that the NITAG of South Africa and AFRO need to have. I'm sure there will be a lot of arguments for that transition as well as against that transition. Thank you.
I don't see any more questions. Should we move on? Thank you very much, Andre.
Thank you.
Rosamond, will you be sharing slides or do you want me to share yours?
You can go ahead, thanks. Thank you very much, and good afternoon, good morning, good evening to everyone. This is a brief summary of the situation globally with Mpox. You may have thought that maybe Mpox fell off the radar, but we still do have an ongoing global outbreak, and we have an emerging situation in the Democratic Republic of the Congo, which is also causing concern. So I'm going to give you a brief overview of the global situation and the situation in the DRC, and then we will have an update on the most recent recommendations from SAGE as they were debated last week and presented to the Director General thereafter. So this is just a reminder that following the beginning of the global outbreak, a multi-country outbreak of Mpox, with the public health emergency of international concern, which was lifted in May 2023. There was then a review committee to review the response, and that was followed by the issuance by the Director General of what are called standing recommendations under the international health regulations. These are available online. They're 3 or 4 pages long. This slide is just a summary, but these standing recommendations are still in effect until August of this year, and they will be presented also to the World Health Assembly in May. So you have here recommendations to member states or to states parties under the international health regulations. And just to mention that these include the ones I've mentioned in red, which are to invest in research to better understand Mpox disease and transmission patterns, and to develop improved vaccines, tests, and treatments. And then the last one is also that member states and all partners should work towards equitable access to safe, effective, and quality-assured vaccines, tests, and treatments for Mpox. Next slide, please. So on this slide is that data that was just published this week now, or yesterday, including data from February 2024. So what we have here is the classic epi curve that you have seen possibly many times of the outbreak globally, which now has reached 94,000 laboratory confirmed cases in all 6 regions of the world in 117 countries. There was a rapid response in some cases in many countries, including vaccination, but obviously not in all. And they included also community engagement, risk communication, and many other actions. The response, as you can see, has led to a rapid decline in the number of cases in early 2023. However, a year later, we are still in the situation that we are seeing today in February, which is that over 700 cases were still reported in February from 29 countries. So we are well outside the classic list of endemic countries in the African region. Cases are still being reported from 5 WHO regions. On the right, what you see is this an amplification visually of the tail end where we are today. So you can see that the outbreaks in the Western Pacific region and the Southeast Asia region came later but have tailed off, whereas there are equal numbers of cases more or less being reported from the Americas, from the European region, and from the African region now. Next slide, please. So this slide summarizes where we were towards the end of 2023 with the situation emerging in the Democratic Republic of the Congo. If you look at the graph on your top left of the slide, what you see is a number of clinically compatible cases being reported since 1990s. In fact, they've been reported in that country since 1970, but very sporadically at first, shortly after the era of smallpox vaccination had just stopped. And now with each growing cohort of population which have not received smallpox vaccine, this may be one of the factors behind this significant and easily visible increase in the number of reported cases. These are classified as suspected cases in the country. because only 10% of cases are actually laboratory confirmed. However, even these suspected cases do meet the national case definition. They are not simply rash and fever, syndromic approach. They do, in fact, meet the classic case definition for Mpox. So what you can see is that in 2024, that data there is not annualized. That is data for the first 2 months of the year. And there definitely aren't countries on track to report more cases in 2024 than were reported in 2023. So it's clear that the trajectory of the outbreak may still be upwards. Also in that top left, what you see is the case fatality ratio as reported over the last 4 years, including this year, where it has risen from 2.7% just 3 years ago through 3.7%, 4.7%, and this year we are tracking to over 7% case fatality ratio. That is the number of deaths reported over the number of cases reported in the country. This is obviously very concerning, and we have other features that also lead to some concern. In the center, you see the map of the DRC and the cases that are the provinces that are reporting cases in 2024. But by the end of last year, in fact, 23 of 26 provinces, including the nation's capital, had already reported cases, some of them for the first time in 2023. And that included Kinshasa, it included South Kivu. The outbreak in South Kivu was different from the outbreak in endemic areas because it was an outbreak linked to sexual transmission and an outbreak in sex workers. 30–40% of the cases are in sex workers, and the rest of the cases are in the community, including a few children. So what you see on the left, bottom left, is the classic demographic pyramids for the cases as they were reported in different parts of the country. This was from the mission, the joint WHO Ministry of Health mission that took place in late 2023. So this data is from 2023, but it shows you in Equateur, which is the most endemic province. Bolomba was the most affected health zone at that time. It has now moved to Lutumbe. But in Bolomba, we saw a demographic pyramid of cases, which was really clear that showed us really clearly that most of the cases are in children under 1 and under 15, under 5 and under 15 as well. On the right, you see a very different demographic pyramid, and this is the outbreak in Kamituga, South Kivu, which shows that sexual transmission of Mpox due to clade 1, which clearly is more virulent than what's been happening globally, is showing that the pattern is much more in adult men and women. It's the first demographic pyramid I've seen for Mpox where there are more women than men affected. In the South Kivu area, these cases are occurring in mining areas, border areas, where there's a lot of population movement across borders, either because of commerce and mining, or also because of civil unrest and population movements. Next slide, please. Now we're looking at data, which is the last 2 years as well as for 2024. So again, this is the first 8 weeks of this year, where we have on the left the number of cases being reported and on the right the number of deaths being reported. This is not yet incidence. We're also working on producing maps and graphs that demonstrate incidence. Right now, these are case counts, but even that shows that there's a significant departure from the patterns even of the last couple of years. Next slide, please. This slide illustrates, again, the age distribution. In the top left, you have your pie chart, which shows cases in infants under 1, children under 5 years, approximately 1/3 of cases, another 1/3 in children 5 to 15, and then 1/3 of cases in adults. The distribution of deaths among the age groups looks similar, except that for children up to the age of 5, that they represent 2/3 of the deaths. So clearly their children, younger children are at higher risk from severe disease and death, as well as from being cases in the first place. On the right, you see the age and sex distribution of laboratory confirmed cases. Many of these in the early part of the year were in fact coming from the outbreak among adults in South Kivu. This is now evening out as we're receiving, the country's receiving more specimens from the endemic areas. Next slide. So in summary, there's a continuing rise in reported cases and deaths in the Democratic Republic of the Congo. 1 in 5 health zones were already reporting more than 3,500 cases in 2024, and more than 2/3 of provinces. About 10% of the cases are laboratory confirmed, which is already not bad given the very large size of the country and logistic challenges, but clearly it means that there are still many questions about what could be causing what looks like Mpox in the remaining 90% of cases. There are combined outbreaks of measles and Mpox, both confirmed in the same health zone in Lotumbe, Equateur, for example, and so there are the population is facing a number of infectious disease challenges, amongst other challenges, and both are affecting the health of children. So also what we've seen for the first time in 2023, the first time it's been documented, is co-infection of Mpox with sexually transmitted infections. We saw this globally in the global outbreak. We're now seeing it in the DRC, and the examples of documented co-infections include Mpox and HIV infection, or Mpox and HIV and syphilis. Another concerning feature is that there are strain variations. The strain of monkeypox virus that's circulating in South Kivu is not exactly the same. It's still clade 1, but it is a different lineage, if you will, than the strains that are circulating in the endemic areas. The ones that are circulating in South Kivu have gene deletions, which can lead to diagnostic failure of the PCR tests, which are specific for clades 1 or 2. And so WHO is updating updating interim guidance on laboratory testing for Mpox to provide information to countries how to assess testing algorithms to ensure that this gene deletion, which may lead to diagnostic failure, does not prevent the detection of clade 2 indeed, but also clade 1 monkeypox virus should it be circulating outside of the DRC. Next slide, please. And so just a brief background on some of the data that SAGE did review last week. We have different vaccines that are available for Mpox. They were developed as smallpox vaccines. You may know that the vaccine itself is not the virus that caused smallpox. It's a different orthopox virus called vaccinia virus. Orthopox viruses do offer protection against each other. And so the vaccinia virus is what is now effectively known as smallpox, Mpox vaccine. So the post-exposure prophylaxis for the one of these vaccines, which has the most data available for it, has been shown to be not very high. The data showed that post-exposure effectiveness was 20%, which was disappointingly low. This is partly due to the difficulties in measuring vaccine effectiveness and obtaining an appropriate control group, but it may also be in part due to the sexual transmission in the study group, which is these studies all arise from the global outbreak of Mpox among men who have sex with men in high-income countries, mostly, not exclusively. And so it is the case that the average incubation period is shorter than it was in the past, than has been documented to be in the past, which means it may be challenging for the vaccine to be effective in a shorter period of time and offer that immune protection before a monkeypox virus infection it becomes a reality. So the post-exposure prophylaxis vaccine effectiveness is unfortunately low in that setting, but needs to be assessed in other settings with different modes of transmission. The good news is that for the same non-replicating vaccinia virus vaccine called MVA, there is a 76% estimate of vaccine effectiveness for a single dose, and it is a 2-dose schedule. So the second dose raises the vaccine effectiveness to 82%. You can see the confidence intervals are quite tight around those estimates, which gives us good confidence that even though these are observational studies and not randomized clinical studies for vaccine efficacy, it is still very reassuring that many of the studies, if not almost all of them, are showing similar evidence of vaccine effectiveness for prevention of Mpox when the vaccine is given prior to exposure. Next slide, please. The other aspect that was reviewed in detail was vaccine safety. As you know, these vaccines, the original versions were called first-generation vaccines. They were used to support, along with the surveillance containment strategy, to effect eradication of smallpox, one of the most feared diseases in the world, before it was eradicated in 1980. So these vaccines that we now have were in fact developed after or at the end stages of the smallpox eradication program, and developed so that they would be safer and available in the event of resurgence of smallpox. We're not aware of any resurgence of smallpox at this time, but the development program to develop these safer vaccines is what has led to the availability of these products for Mpox prevention and control. So the second generation vaccines, then it gets one example is known as ACAM 2000. Other countries do have their own other second generation vaccines. Does have a higher profile of serious adverse events, which include, for example, myocarditis. The risk is still 200 in 200 cases per million doses. So it's not extremely high, but it is still high in the sense that, of course, if smallpox is not there, then the risk-benefit ratio changes. And so this vaccine has not effectively been used to any great extent in the global Mpox response. However, the other two vaccines are, again, improvements upon the second generation vaccine. They're called third generation vaccines. LC16 is minimally replicating. It's approved for use in Japan, and it's the only vaccine approved for use in children. So it has a good safety profile demonstrated through assessment in 50,000 children, and no serious adverse events were reported. Similarly, modified vaccinia Ankara is a non-replicating vaccinia virus, still a live virus, but non-replicating. However, it is only licensed for persons 18 years and older. So there is limited data on MVA use in children because, of course, in the global outbreak, most of the persons affected were adults. However, there's two studies, small studies with a total of 159 children in which this was studied in detail. And there was a surveillance report of a further 1,000 children from the United States of America who did receive MVA-BN. And with all of these, there is again shown a good safety profile with no serious adverse events. In addition to that, the MVA, the modified vaccinia Ankara, is a platform that is being used to develop other vaccines. And MVA-BN Philo is Ebola virus disease vaccine, which has shown a good safety profile in 52,000 persons and is licensed for use in children age 1 and older. I think it was 52,000 children. So we do have some evidence of a good safety profile for MVA-BN as well, even though it is currently not licensed for use in children. Next slide. So the recommendation from SAGE is to put all of this together, given the old epidemiology, the original epidemiology in Africa, the new epidemiology globally, and now this emergence of this very concerning situation, again, in Central Africa, and put that together with the vaccine safety and vaccine effectiveness data that is available to date to present this recommendation for consideration for use of Mpox vaccines. So vaccination is recommended for persons at high risk of exposure to Mpox in an outbreak. This was already said before in the other interim versions, but this is again reiterated by SAGE in this version of the recommendations. Vaccination should be based on local epidemiology and persons who identify to be at risk, although it is acknowledged that members of it, this may be difficult in some areas where the epidemiology is less well understood. So local epidemiology may include vaccination of persons in a geographically defined area, not just a population group at risk, but possibly a family, a village, a community, and that this would likely include children, clearly in the situation that we have seen where 3/4 of the persons cases that are reported are among children. In addition to this, the same recommendations that were there before continue to apply, which is vaccination should be considered for sex workers, gay, bisexual, and other men who have sex with men with multiple sex partners, or other individuals with multiple sex partners. So again, it's about the risk of sexual transmission of a virus that is still circulating globally. In addition, of course, we want to protect health workers. SAGE recommended that health workers should still be considered for vaccination if they're at risk of repeated exposure, and this would include clinical laboratory personnel, healthcare personnel performing diagnostic testing or providing care. Despite the findings on post-exposure prophylaxis of a relatively low vaccine effectiveness, the recommendation of vaccinating contacts of persons with Mpox was maintained, partly because that the study results that we shared with you are from a very specific population group globally, and it may be that the findings are different in different settings. Nonetheless, SAGE has emphasized the importance of vaccinating contacts wherever possible within 4 days of first exposure. Contacts in this case may also include children or others in the household or congregate settings, such as prisons, schools, health facilities, or residential facilities. Next slide. So this is just a summary slide for non-pregnant immunocompetent individuals. So most people that WHO does recommend for most people that non-replicating vaccine, minimally replicating vaccines, or even replicating cell culture derived vaccinia-based vaccines, or that meet WHO standards for quality are appropriate for use based on obviously a risk assessment at the time, risk-benefit assessment for individuals or for population groups. And that specific considerations, including potential off-label use, apply as to the vaccine choice for each of these special population groups. And then SAGE went into some detailed recommendations. We won't go through all of them, but we will see that in the next slide, we have a couple of examples. Next, oh, sorry, previous slide. So in the choice of vaccine for infants, children, and adolescents, given our new situation or continuing situation emerging in Central Africa, where consideration is given to vaccination, non-replicating or minimally replicating vaccines should be used. We've already been through the facts here that LC16 is already approved for use in children. And while MVA is not approved for use in children currently, it may nonetheless be used in an off-label way. This has been specifically recommended by SAGE that off-label use of MVA-BN be considered for children. However, replicating vaccines should not be used in infants. That's a clear contraindication. And WHO recommends further data collection on vaccine safety and effectiveness in different population settings. Next slide. Of course, SAGE also mentioned the research priorities that are classic. A better understanding of modes of transmission, of the epidemiology, including age-specific cases, incidence, deaths, and seroprevalence, and characterization of risk factors for infection and severe disease. In particular, the epidemiology in children and the understanding better vaccine effectiveness, safety, and immunogenicity in this group, for which very few studies are available, at least for MVA, that's the case, then that's also a priority, as well as the duration of vaccine protection. Occasionally, SAGE will also issue a call to action, and this very much came from SAGE members to emphasize that they wanted this call to action to be issued, to emphasize the importance of availability and access to vaccines, of advancing on regulatory vaccine assessment and procurement processes, of making sure that there's ongoing systematic data collection during deployment of vaccines, in other words, embedding research in emergency deployment of vaccines for immunization for Mpox, and of ensuring and enhancing sustainable investment in research capacity in the African region. Next slide. This is just to give you a heads up that in early April, WHO will be issuing a global strategic framework for enhancing control and achieving elimination of human-to-human transmission of Mpox. This may sound counterintuitive given what we've just said about the situation in Central Africa. However, we know that at origin, Mpox is was a zoonotic disease. However, we also know that certainly globally, all cases have been acquired through person-to-person transmission, and that even in the African setting in endemic countries and even in endemic areas within those countries, that there is a high proportion of cases that are acquired through person-to-person or human-to-human transmission. So really the focus of this is not to say that the zoonotic disease will disappear necessarily, to enhance research in that area as well, but there needs to be a concerted effort to achieve control of Mpox in every context, to advance Mpox research and access to countermeasures, in order to reduce and stop human-to-human transmission, and then also to minimize animal-to-human transmission through better understanding of what is leading to that, which right now very little is actually truly understood. So this framework will be issued in April, and it will come in to support standing recommendations that I mentioned at the beginning of the presentation. Next slide. That's it. Thank you very much.
Yeah, thank you. We do have one question, and it's asking if there is enough vaccine available for DRC at risk groups.
So the answer to that would be probably not right now. But there are many steps that need to be taken to enable vaccine access in the highest risk settings. So first of all, these SAGE recommendations will go towards supporting any and continuing work in that direction. Secondly, there needs to be regulatory approval in the country. So one thing that's interesting and good to report is that Nigeria has actually just succeeded in achieving approval for emergency use of MVA-BN in Nigeria. This is a recent development. It took a year and a half for them to do that with bilateral support from a stringent regulatory authority. And right now, the approach for the Democratic Republic of the Congo is being supported by the regulatory team in the African Regional Office of WHO to do the same approach, to have a bilateral support, which will be much accelerated. It shouldn't take as long in this circumstance. Following that, of course, immunization strategies need to be developed based on vaccine availability. So there are some small donations of vaccine presently being offered by high-income countries. WHO is working to secure additional donations, and we are aware that the manufacturer of the MVA-BN, Bavarian Nordic is the manufacturer, that they are also able to make more than 1 million doses available within the next 6 months and possibly more. But of course, then there needs to be a procurement mechanism as well, and those vaccines are not the cheapest. For the LC16, there is not the same amount of data available. Japan has used the vaccine, and Colombia has used LC16. So we're waiting for clinical trial and observational data on vaccine effectiveness to come for LC16 as well. And what is proposed for the DRC for LC16 is that that vaccine be used, and Japan has also offered 50,000 doses as a donation to DRC to use in clinical trial and assess the effectiveness of that vaccine in the Central African setting. So we have quite a number of areas of work that we're pursuing simultaneously in order to support the country to make these vaccines available to the groups at highest risk. And that work on immunization strategy is also beginning now to use an incidence-based approach for vaccine deployment. In the future, many more vaccines will probably be needed, but little is known right now about the duration of protection against Mpox. So we also don't know that if there is immunization of groups at risk, how long that protection will last. Next slide. Sorry,
Thank you very
next
much,
question.
Yeah, I don't see any other questions for you, so I thank you. If another one arises, we'll give to you. There is one pending question about bOPV. Maybe Joaquin can answer that, and it's about OPV cessation in routine immunization, and asking if there will be a shortage of IPV. So Joaquin, could you answer that?
Sorry, I didn't understand. It's for.
Yes, it's for Joachim. It's on
Okay.
Polio, Rosamond.
All right, thanks.
Yeah, it's
Joachim, yeah.
just checking if Andre is still around. I mean, yes, I mean, of course, there needs to be enough IPV. The IPV situation has in the past been tight. I think we have now ample supply, but I don't have now the details. But it's clearly something that needs to be planned in. Totally agreed. But I think the IPV supply situation is comfortable.
Okay, before I hand over back to Mario, I just want to share that the GNN will be, sorry, not the GNN, WHO HQ will be doing a survey for NITAGs from middle-income countries to understand their specific needs. This survey will be sent quite shortly to the NITAG Secretariat and NITAG Chair. The idea is to send it to all NITAGs in middle-income countries. So we do count on your participation to reply to this survey that will then inform us on what specific guidance, training material that we need to develop for you. So please keep watch out for this survey, and we count on your participation. And Mario, I hand over back to you. And just in case you forget, yes, the presentation will be shared with all participants and with all people in the mailing list. Over to you, Mario.
Thank you, Liz. And we just right on time. Just to let you know that the next webinar will be in May. It will be about rabies. And a big thank you to all the panelists. This is really, really important information for all of us. And it's really, really good to have it firsthand from you. So thank you, everybody, and see you next time.